Okay, you're getting somewhere. Okay. Oh, are you okay? Yeah.
Oh my God.
That goes viral now.
Holy crap.
That
Gosh.
goes, that goes viral.
Oh my gosh.
I know. Somebody put my chair away. What did you do?
It's on film, so you can see I didn't do it.
Okay, well, we need better chairs. Okay, I'm all okay. So we are going to talk about obesity and a case and the relationship of the obesity to the spine. Let's see here. Let's go to the Facebook. And I'm going to get the one of our obesity case. What's Mike? What is obesity? Define it for us.
Classically in medicine, we define it as a BMI over 35. But there's a lot of different other definitions. Some people define it based on waist circumference. Some people define it based on a combination of muscle mass versus adipose tissue.
Mhm.
So it's kind of a chronic condition that we face a lot in our society due to sedentary lifestyles and excess of calories.
Yeah, well, you know, can you go a little help us with understanding BMI?
Yeah, so BMI is kind of a loose, it's a calculation that loosely is supposed to guide our clinical decisions. And it was invented a long time ago, actually by an insurance company, but it's basically just based on your kilograms versus your height. And it's kind of a ratio.
What is the sense behind the BMI? Why not just the weight? Hi, Neil, how are you?
Hey, doing good. How are you?
Good, good. I just fell on my chair. That will go viral.
BMI, the reason that versus just weight is obviously if you have someone 5 foot versus someone who's like 6 foot, they shouldn't weigh the same amount. So you can kind of factor in height and body composition.
Yeah, because you know, obviously, if you have a child, the child is like 20 pound, and is not underweight. It is it's a height versus practically weight. It's a calculation, and it is what is the unit of the BMI?
Isn't it like meters per kilogram or something?
Yeah. Okay, Neil, what is the unit of BMI?
It's kilogram square. Hold on.
Per square meter.
Per square meter, right? Okay.
Yeah. So I'm still trying to get to my Facebook account. Today we are going to talk about something that doesn't matter where in medicine you are. It has relevance to what you do. It has relevance to any kind of care you're providing. It's a huge, obviously, public health issue, but as well it has lots of relevance to the care we provide and how we provide the care.
Right.
Did you talk in your med school about obesity and so on?
Yeah, definitely. And what I've understood, especially from BMI, is I know lately there's a lot of scrutiny on it because of the way that the system was created and the data that they pulled from was not diverse enough to encompass, you know, the individual basis of someone's BMI and what that means for someone. But one thing that I have personally learned in medicine is that we have a lot of tools and we have a lot of systems to try to understand a patient. And we should also understand the limitations of those things. So yes, BMI isn't a perfect tool that can be utilized per an individual. But I guess when you're looking at a population base with a larger sample size, it at least gives you an idea. You shouldn't use it as an absolute, like, oh, because your BMI is 1 point over this level, this is my opinion. It's more like it is a tool that should help your total understanding of the patient.
It's it's one factor, one information that you bring into your, and again, it's more important than just the weight, because somebody who's taller is going to be more heavy. And that does not mean they are unhealthy or that this consideration works for them. Now, let's categorize. What is the average BMI?
17.9 to
What?
to 24.9.
Is that the case?
I believe so.
17 to 24?
17.9, I think.
And I'm already obese.
To 25.
Yeah.
To 24.9. 24.9 is the upper limit of normal, I think.
Okay, but when do you call people overweight versus obese? Neil, you chip in.
So overweight is 25 to 29.9, and then obese is above 30.
Obese about 30. Now, I thought overweight is actually 27 and above. So it's now the thing has changed.
I guess it probably depends on the criteria you go with.
Yeah.
Different hospital, because actually today I was reviewing a patient's chart, and one hospital said that this guy's red blood cell count was high.
Okay.
And then I looked up the Mayo Clinic's actual range, and Health Partners is using a different reference range. I think it depends on the place.
Okay.
But I think classically above 25 is considered.
Well, so, but we agree that anything above 30 is called obese. What is 35? Above 35?
Morbid obese.
Morbidly obese?
Yeah, or severe obesity, morbidly obese. What is BMI above 50?
I don't know.
Have you seen somebody with a BMI of 50 or 60?
I've seen the largest patient I saw was 83.
Okay.
Wow.
83. Can you describe what you saw or your observation there?
So she was coming to us for wound care, actually, and she had a chronic wound on her right lower extremity, and she was very, very large, had a lot of trouble moving, but she could ambulate, but she had a lot of trouble. She had to move very slow, and she had this chronic wound. I think part of it was because of lymphedema, and part of it was because of diabetes. And you could take this, because she was there for wound care, so we would stick our instruments in, and we'd go in like 4 inches into the wound to get to the base of it, because her leg was just massive.
Yeah, in this kind of situation, sometimes their own weight is enough to cause decubitus and problems. So I want to show you a case. Let me see if I can find it on it. Somebody, definitely the highest BMI that I have operated, 62.5. And let's see if I can find that. But generally, when you treat, first of all, let's start with basic things. Even the basic physical exam has become almost impossible in the BMI like that. Like, how do you even listen to heart?
Yeah.
Have you ever tried to listen to heart of somebody with a higher BMI?
It's difficult.
Well, it is practically lots of or auscultation or any kind of exam.
It's not as sensitive with your physical exam.
Yeah. So you have to almost rely on different tool to even do that. But as well, the obesity itself is a disease, but it impacts as well many other diseases like the cardiovascular disease, pulmonary disease. One of the problems that we have with the high BMI is even getting pictures in the wall. And obviously working on a deeper kind of hole, like you say, you had to go on the deep of a 4-inch hole to get even the packing of the wound and so on. Now imagine you don't have to just pack it, you have to do actually surgery there.
Yeah.
That becomes actually a bigger deal. Now, as a matter of fact, most of our societies in the spine are recommending not to do any surgery with a BMI of above 40. It seems that is the risk versus benefit. At least in the open surgery, it does not seem to be justified. I just did though. Somebody with a BMI of 50. We did a 2-level fusion. By the way, that patient is doing fantastic. That patient was told by 2 other surgeons that he would not qualify for the surgery. And we did that in 63 minutes. We lost 31 cc of blood. And when I say 31 cc, I mean 31 because we don't use suction. We use the sponges before and after. And that patient most likely will go home today. The wife was asking me if they can go home today. I said, maybe it's a good idea to stay over the night. So why is it that we can do that surgery and that open surgery cannot do? What do you think? What's the difference?
Well, we do more of a posterior approach. So obviously everybody knows when they see someone who's very large, they carry a lot of their weight anteriorly and kind of like the visceral area. And with a posterior approach and a minimally invasive approach.
I don't believe the posterior approach is what really matters, is that the minimal invasive approach that really matters, because our societies are very clear with BMI about 40, 80% of our surgeries are TLIF, which is the posterior approach, but they don't recommend to do that because you have to go through deeper hole, cause a lot of trauma to the tissue to get the surgery done. And that is the point that, that in open surgery, this becomes truly a tremendously invasive, over proportionally invasive procedure that you don't want to put the patient through. Now, I'm still trying to BMI 50. Let's see.
You could just Google it probably.
Yeah. This is let's see. I want to actually find that specific case, which we published actually in our in some of our paper. So here it is. Let's start with this. I'm going to share it. And let's just start talking about what we see here. And I'm going to change it so everybody else as well sees that. Neil, are you able to see this?
Yes, I can.
So can you describe, we went through a lot of reading of our films. You want to start describing, first of all, what you see?
Well, it looks like this is the abdomen. I see of the patient. I see the.
You see that there, right there you are. It looked like abdomen, but this is not abdomen.
Really?
This is spine. This is paraspinal muscle. It's like, this is what you would call for a good steak, you would call it marbling. Do you know what marbling is?
I do know what marbling is.
How do you know what marbling is?
Because I like steak a lot.
Yeah, here you are.
Yeah, so when marbling is when the fat is interspersed throughout the muscle tissue so that when you cook the steak, it's richer, softer.
Yeah. What is the most expensive kind of steak with the best marbling?
Oh, are you talking about like Kobe beef? Or are you talking about the cut?
Just generally, the most expensive steak is not the pure meat.
A filet mignon.
No,
but I'm talking about when you go or you have your steak in different thing, but the steak that is marbled most is the most expensive one because that has the most flavorful kind of steak.
Well, I don't mean to cut you off, but we have someone in the waiting room, a classmate of mine. His name is.
Okay. Well, I apologize. Let's just go there.
Yeah, no worries.
Yeah,
let's sit and think about steak for a little bit.
Well, now let's talk about that. The marbling is that when there is a lot of fat between the muscle fibers, and if that ratio is like almost 30, 40, 50%, that during the cooking process or barbecue process, grilling process, that gives a lot of flavor. But then when you look at that, as a matter of fact, I want you to see literally that there's a reason. This is not just for entertainment. I want you to see marbling of steak.
I actually just cooked some steak last weekend and I got a New York strip. And when I was picking it out, I tried to find the best, most well marbled cut.
Yeah.
It turned out good.
Look at that. Which steak do you think is the most expensive? The most marbled one is the most expensive. Okay. Because then all the muscle tissue. Now, look at that picture, which is an actual picture of a steak, or actually, maybe it's just a I want to go and look at actual meat here.
Oh, wow.
Look at that.
Yeah.
Okay. You see that there?
I think you have to share your screen again.
Oh, I haven't shared my screen yet. Okay, here we go. Here, you see it now?
Yeah, marbling of steak.
Marbling steak. Do you see that there?
Mhm. Is that the fatty deposits within the muscle? Is that what-
Yes. Yes, that is exactly the fatty deposit. Now let's go look at this here. This is almost 80%, 70%, 80% fat. And those little dark spots you see, those are the muscles. You see that there?
Mhm.
Look at the amount of the fat around the kidney.
Yeah.
And obviously everybody has a certain amount of fat around our inner organ. That's what protects us, right?
Yep.
The fat has a function. Like, so who's joining us? That is Joan.
John.
This
John?
is John. He's a classmate of mine.
Okay,
He's also
John.
been to many of the sessions.
John, what is omentum?
That's just like the fat that protects like your bowels, right? That overlies your bowels.
It's a curtain of fat and immune tissue. It's not just fat, it's immune tissue. As a matter of fact, we know for a long time that fat in our body is part of our immune system. It's part of our immune system. And when you have you been in any abdominal kind of surgery?
I have, yeah. I've
Yeah.
actually been in a partial omentectomy.
Yeah, it is like you see that this fat, and then when you go, you see that most of our bowel is connected with the what is called what connect the bowel to vascular supply. You know, the bowel, they have like a small little omentum is truly like a curtain, but beside that, our bowels are connected with the fatty tissue as well to where they get their vascular supply and so on. And that is all of that is part of our immune system, where they get all the material from the bowel, and then there are lots of lymphatic tissue. As a matter of fact, part of that lymphatic material, they take a different path, right? And lots of blood supply from our bowel goes to liver. Some of that bypasses that, goes through.
Oh, is it like the cisterna chyli? Is that what you're saying?
That part of that goes next to our vena cava in the back of the lymphatic material, that fatty material. There's lots of immune cells there. What is the purpose of having so much immune system in our omentum and in the fatty tissue around our abdomen? Because there are lots of stuff from outside world getting to our bowel, and some of that may penetrate through our guts, to our lymphatic material, to our bloodstream, and we have to be prepared for practically overcome if there's any other tissue. So there's some fat there for normal, but this is not normal. Can we agree that this is like 70% fat or 80% fat, and just those dark spots, if you consider them, and it's so bad that Neil at first thought it is the abdominal cavity. This is not. This is the paraspinal muscle. And this is another picture. Oh, I think you're echoing. Somebody is echoing. So we agree that this is like 70% fat or 80% fat. I'm going to mute you. So, okay. I think it's possibly you, Neil, that is echoing. So this patient, this is now an MRI of the spine in a different view. Okay. This one.
Could you share your screen again? I don't think we're seeing it.
Oh, okay. So here it is.
Thank you.
So this is the T1, so-called T1. Okay, now let's go to look at the T2. In the T2, you don't see all the fat because it's all white. It's just not the right window for that. But go ahead, Michael, describe what you see.
So I see a sagittal view of the lumbar spine.
How do you know it's, I told you it's a T2. How do you know I'm not lying? How do you know it's T2?
Because I can see the enhancement of the spinal cord.
You don't call it enhancement. Enhancement is a word reserved if you give contrast.
Okay.
Then you call it the enhanced, and that there in the myelogram, which is a CT, that would be enhancement,
Okay.
because then you introduce omnipac or a contrast to the CSF space. But this is not an enhanced picture.
I guess I can just see the increased detail of the spinal cord.
Water is white.
Yeah.
In the T2, water is white. That's why we call it pathologic view, because anything in our body, like what happens if I hit you really hard here?
I'd bruise.
It swells up.
Yeah.
What happened? What is the Neil? What is the pathological mechanism of swelling if I hit him hard and hopefully he doesn't hit me back?
Would it be capillary damage, tissue damage? But I'm
what
assuming
happens?
it's capillary damage.
But when you have capillary damage and so on, John, when you have capillary damage and when your tissue swells up, what happens in that tissue?
There's just like acute inflammation. So they're sending, or your body is like sending, repair enzymes, white blood cells, things like that. And so
repair, I would say repair cells.
Okay.
Yeah?
Repair
What are
cells,
cells mostly made of?
Mostly liquid.
water.
So water, we did that the podcast before about what does MRI measure actually? What does MRI measure? Protons, hydrogen. Water has lots of hydrogen, okay? So that's why we call T2 sequence pathological pictures. T1 we call anatomical pictures or sequence. T2 we call pathological, because T2 specifically measures water, proton water, and water is white. Okay, so if you see a lot of fat is white too. It's a little more complex than that, but CSF is has lots of water. That is white.
Yep.
Right. So this is what is this right there?
That'd be the disc.
That is the disc. Disc is a normal disc has lots of water, so it would be white inside.
Yep.
And the bad disc is actually dark. But generally, in the rest of our body, if you see swelling, if you see lots of fluid accumulation, lots of white, that means that's usually a pathological sign. So, Neil, I'm going to go over some structure. Tell me what they are. We talked about that is the disc. What is this?
Would that be the paraspinal muscles?
Almost, but it is not paraspinal muscle, because when you see the spinal cord, you are not para next to spine. You are right at the spinal canal, right? So what is right in the back of the spinal canal?
So would that be the erector spinae muscles?
No, erector spinae muscle wouldn't be there. No, right in the middle of the spine, posterior.
Would that be the ligament that connects the spinous processes?
There is definitely some ligament, but before even there is a ligament, let's see, spine anatomy. So, right on the back of the spine, spinal canal. What is right in the back of the spinal canal?
Oh, the ligamentum flavum, is this what you mean?
The ligamentum flavum, oh, you're digging a hole there, Neil. So, ligamentum flavum connects one lamina to another. Certainly in the middle of the spine, there is lamina connected. So definitely there is some ligamentum flavum there. But if you cut the spine exactly in the middle, what is the most posterior part of the spine? It's in front of you. You see it right there. What are these structures here?
The spinous process?
Spinal processes, correct. So, and in a midline cut or midline the dissection or plane of the spine, you would be seeing plenty of spinal processes. It doesn't show up very well there because the cut might be a little to the right and left, but these structures here, do you see them there?
Mm-hmm.
Those are spinal processes. But all of a sudden, you see this mess here. You don't see spinal processes there. You see a mess here. What is that?
Is that the squished adipose tissue?
Yes, it is.
Is that marbled steak?
Say one more time.
Is that the marble steak you guys were talking about?
No, it is worse than that. It's worse
Is
than
this a sign that there was either injury or prior surgery in this area?
that. Correct. Very good.
Oh.
So you don't see the spinal process. Some procedure removed all the spinal processes there, and as well the laminas there. So what is it, that process called, if you remove the spinal process and the lamina?
Is that a laminectomy?
Yes, patient had a laminectomy.
Is it
3,
multiple
4,
levels?
5. So 2. No, 2 is still probably is intact. I see still a little of it, but definitely 3, 4, 5 laminectomy.
Okay.
Okay, so that's a process that they went and removed the lamina, and obviously spinal process is connected to the lamina, which is connected to the pars, connected to the facet. So there's no way you can keep the spinal process in place without, if you remove the lamina, you automatically are removing all the spinal processes. Does that make sense so far? Okay, so here we are there. You see the scars and laminectomy. That's what we call. If a neurosurgeon or a spine surgeon would say, MRI of the lumbar spine, in the sagittal view, in the T2 sequence, I see the patient status post L3 to 5 laminectomy. Now, let's just talk a little more. You know, what is this structure here, John? Do you know what? Do you see my cursor right there? Right here?
Is that part of like the sacrum?
This is actually, yeah, it is S1, S2 sacrum. That's a sacrum. Now, this is abdominal fat, and it's hard to say just from this cut, but it's something dark is going all the way down in front of the spine, which ends at this level at L4. What do you think what that is? This structure that goes all the way down and ends up at L4.
I have a guess. The aorta.
Yeah, aorta.
Yeah.
Why does aorta ends at L4?
No, it just splits.
Splits to what?
The iliac arteries.
Iliac arteries. So you wouldn't see it here because then they go to the side. Okay, so good deduction. Very good. Now let's look back here. Now, obviously, they did a laminectomy, but call it God, call it nature, call it evolution, call it whatever you want. Put that spinal process and put that literally the lamina in place for a reason. Okay? Why do we have spinal processes? Any guess? Why do we have?
To prevent hyperextension of the back.
No, we call it a process, right? We have other things there as well. We call it like the transverse process, or
is it a site for attachment?
Correct. What attaches there?
Well, we have ligaments and muscles that attach
Correct.
there.
Perfect. Yeah, that any process is attachment for ligament, mostly spine, but as well ligaments. Okay. Now, if it's a process, if it's a true process, is 99 out of 100 times is a muscle. So why use our body, our skeleton, these processes for muscle attachment? Any guess?
It's like for proper posture, like keep our bodies upright.
To see what is a crowbar? You use a long arm to provide more like a lever. So these processes are muscle maximized with a minimal motion, with minimal motion of the muscle, maximize the actuation and actual, or vice versa. Sometimes it's the other way. Sometimes it's that a little motion of the muscle becomes a lot of motion of the bone. Sometimes the other way. So most of the processes are practically a fulcrum or a lever action. Okay. And here you see that in the transverse process and the spinal process, all the same. Now, let's go back there and look at a few more pictures here. Now that we understand what they are, now you remove them, what happens?
You lose stability, you lose that strength and the leverage that you're able to produce.
Yeah, so by the time you do laminectomy, you don't reattach those muscles back. There's a, do you guys understand what the process of laminectomy entails? What does the laminectomy entails? Let's go to Google and see laminectomy. Let's see what Google says.
I think you have one of these on Monday.
Yeah.
I've been doing a lot of your pre-op calls. So.
Yeah. No, that's why I'm doing a spinal tumor. I'm doing a laminectomy to open up the space, to open up the dura. We will come back to that. After we do that surgery, we should present it.
I'm very interested to hear about it.
So, but here, generally, laminectomy, in the laminectomy, first of all, it is not a bone. People are not made out of bone. There's muscle around it. First, we cut the skin. Then we strip the muscle off the bone with a bovie, with a practically electrocautery. And then we get to the bone and then we cut the bone. So what happens when we put the electrocautery, electricity, and on the bone and split it and they take the muscle off the bone? What happens? There are three things happens there.
There's a lot of inflammation.
Well, obviously, but that is, we do it because we want to stop the bleeding. We have to get rid of the muscle from the bone. So we cause lots of dead tissue because we are burning the tissue. Okay, but then we are literally cutting the muscle away from the bone. So that muscle doesn't really have the proper action afterward anymore, and we don't reattach it because we are cutting the bone away. Then on top of that, we are taking the autoregulation of the muscle away because a muscle needs two elements to regulate its action, right? Who knows what those two elements are that autoregulate muscle action?
Do you mean as in the neurons within the muscle?
Yeah, there are specialized muscles that turn into receptor and neurons in the muscle. What do we call them?
Are you talking about like the spindle fibers, the ones that
muscle spindles? What are muscle spindles?
Like the Golgi bodies and stuff like that.
No, Golgi bodies are very good. Golgi bodies are in the tendon. Muscle spindles are modified muscle fibers that practically become part of our nervous system. They tell to our spinal segment, it doesn't go even to brain. That is important now, not to go to the brain. But they go and tell our, practically our spine at the same segment where the nerves are regulating the muscle, what is the status of the muscle contraction? And if it's too much, they shoot a signal, inhibitory signal, and that is why you don't go to spasm all the time, okay?
Is this similar to proprioception when we know your spot in place in space?
Yes and no. This muscle spindle and teldigondan apparatus, they are mostly to regulate your level of contraction and muscle action.
Okay.
But you do have other sensors that tells you at what point the joint is, okay? These are mostly on the joint capsule, tendon, and so on, that literally close your eyes and put a random figure in the air. You have a mental picture of that, what your hands or fingers look like, right? Close your eyes, just do that, exercise. Close your eyes and do a fancy picture, fancy posture with your hands. You do have the exact mental picture of that, don't you? How do you have that?
I do, yeah.
That is a proprioception. That is not muscle spindle. That's not tendon Golgi apparatus. And you can lose that. You can lose that. If you lose that, you cannot walk because you cannot coordinate. You don't know where your joints are, except you compensate. If you have a problem with proprioception and you don't get that signal, what is the way you walk?
Like
Can
a
you
wide
stand up?
gait?
Neil, can you stand up and close your eyes and walk? Yes, you can.
Yeah, I can.
Yeah, because your proprioception.
Mhm.
If your proprioception is out, you couldn't. You would fall.
Okay.
Except you open your eyes and you use your visual system to compensate for that. Okay? So coming back to that, it's not proprioception. This is just to regulate the level of contraction of your muscle, okay? So, and if you cut those muscles in the spine, you lose that for good. The next day you wake up, your muscle does what it does, contracts, but it never stops. That's why they go to spasm, and that's why we have to give them so much medication. And by the time you really recover from that, actually those muscles turn into scar. Why do they turn into scar?
Because they die.
They die. Why do the muscle in the spine after we do a regular surgery, why do they die?
Because once you stop getting that feedback from the nerve, they're
Not auto-regulated. They're dissociated from our nervous system, and muscle that is dissociated from nervous system dies. But it has another effect. When you take the muscle away from the bone gets its blood supply from the muscle. So you're reducing the blood supply of the bone as well. That is why irregular spine surgery is so damaging. Now,
That's why we prefer the OLIF technique.
that is why OLIF technique patient, I just did a BMI 50 surgery. That patient will go home today or tomorrow because I didn't disrupt any of that. So let's go back to this patient. Bone is away, all is scar, and patient has, look at that, herniation, spondylolisthesis. He's miserable. He cannot walk. And he goes to Cleveland Clinic and the panel of surgeons tell him, no, you cannot have surgery. You need a fusion, but you cannot have surgery because surgery will kill you. And they are not wrong about that because
What is the reason for why surgery will kill him? Is it the obesity and operative
because the
under
surgery that
anesthesia?
would fix his problem is a 4-level fusion. That would be a whole day surgery. And this person laying on their chest, on the lung for that long, will not recover from that. Now, let's go back. Let's go a little back. Look at that. After they removed the bone in the back, they didn't stop the process that causing him the problem. The problem is that those discs are gone and they come out, they hit each other, they create more bone. Look at that bone spurs here. That bone spurs directly pushing on the nerve. You can imagine that this patient cannot walk. They told him when he was 400 pounds that go lose 100 pounds and come back. He went and gained 100 pounds. Are you surprised about that? Now, if you cannot walk, you cannot lose weight. And the only, the pleasure you get or any feedback, any kind of activity you have to getting you out of depression is eating even more. So this patient did not actually lose weight. He gained 100 pounds. So he came to us. And again, you see the marbling of that, iliopsoas. Here you see a little bit of a marking of what they are. Now, in this surgery, obviously, we can do the surgery because we are not cutting the muscle. We are not cutting the tissue. We put a tube in. And once you put the tube in, it doesn't matter if you have literally the 2-inch of subcutaneous fat or 6-inch of subcutaneous fat. You do perform more or less the same surgery.
A tube as in you did endoscopic or?
Well, we don't use the endoscope. That's why we don't call it endoscopic, but it's a tube that is about 8 millimeter inside, 10 millimeter outside. And that is how we perform the surgery. I'm going to show you, actually, these are the pictures from the surgery. We use 2 C-arm. And look at that. Do you see that? This is a Jamshidi. Do you guys know what the Jamshidi is? Jamshidi is a certain kind of needle that we use in the spine to access the vertebral body. And I'm going to actually try to see if I have a regular size of a Jamshidi, so you see how big it is. So here are, obviously you don't see that, but let me just see if I have a, so these are so-called the pedicle screws. They are about 6 to 7 inch long. They're just the top of it. Okay, and you see it's at least there's 7 inch of fat between the pedicle bone and the skin. And here the end product, and here after the surgery, and these are the incision. So because we dilate the muscle and go through a tube, we are not causing too much tissue damage, and that is crucial. Now, trying to cut everything and cook all the tissue, these people have like the 20–30% risk of infection. If you create a deep hole there and burn all the tissue, the risk of infection with our surgery is 0.2, because you just make a small little hole and you put a tube in. When you take the tube out, there's no cavity underneath. So let's go back, and I want to show you actually the case that we did today. Let's see. Let me unshare first. And we are going to talk a little about this obesity. Obviously, for the surgery, we have to work a lot deeper to get the surgery done. But I want to show you a video of the or some pictures from the patients today. So far, what question do you have about the dealing with this patient with the obesity? What question do you have?
How do you mitigate the other risks that obesity imposes on these surgeries? Because I know there's the statistics where it's like if you're past a certain BMI, after every extra hour under operation or under anesthesia, your risk starts to jump up by a few %. Yeah.
No, the statistic of that is very clear, that if you randomize, put everybody in the same group, after every half an hour, you're adding 17% to the combined risk of the surgery. But with these people with the high BMI and elderly, 75, the correlation become exponential. It's not linear anymore.
Okay.
That is like this patient, we did our surgery. Let me share my screen with you. So an 8-hour surgery for this patient would have been deadly. But even at our surgery, I'm going to share this with you now again. We did that surgery in 1 hour and 55 minutes, and our blood loss was just 50 cc here. Even after a 2-hour surgery, we could not extubate this patient because this patient is laying on his chest. Everything is good, but you know, this is, imagine, okay, hold your arm like this for 2 hours. See what happens.
Fall asleep and
that becomes useless. That arm, now, if you lay that person on the chest for that long, those muscles have to work the same way as if you are holding your arms straight out for 2 hours. Okay, so those muscles tire out tremendously. Even though we are intubating you, we are putting pressure on your chest, we are helping you out. But I bet you couldn't hold your arm out like 10 minutes.
Yeah.
Okay, so imagine now you do that for 8 hours. That lung has a lot of recovery to do. Even after 2 hours, we could not extubate him right away. We have to keep him actually. We have to keep him, intubated over the night, and then extubate him next night. So this might be the hospital. So I apologize. I have to quickly answer that. But why don't you talk about your experience for a few minutes? Hello?
I'm not quite sure what I'm supposed to be talking about specifically, but I'm Mike. I'm a PA. I got hired here at Inspired Spine. And pretty much right now, I'm just been doing lots of pre-op and post-op calls for patients, kind of giving them some education, checking in to make sure that there's no sign of infections, talking to them about their pain, things like that. So it's been pretty cool to see, I don't know, kind of get a little bit of patient interaction while I'm just waiting for all my credentialing and everything and all my privileging at the hospitals to go through. I actually have a colleague who's a PA who I talked to who has been involved in some of these cases with Dr. Abbasi with the higher BMI patients, and I know they can be pretty challenging. So it's pretty interesting. I actually was looking at this paper specifically that he has up here, and I was curious about, it says OLIF, and then MIS, I think it's DLIF, which I think is a different technique, direct lumbar interbody fusion. So I kind of want to ask him about that.
Is that DLIF or is that PLIF?
I think it's DLIF, it's direct lumbar interbody fusion. So I think he might have used an OLIF for 2 of the levels and then a different surgical technique, which is also minimally invasive. Sounds like he's off the phone now.
Calling, and we have to finish it up so I can go and take care of the
Direct
patient.
lumbar, is it direct lateral? I believe.
So I have a question about so I see the 2 levels were done with an OLIF, and then next to it you have a note that says MIS DLIF.
Oh yeah.
Is that direct lumbar interbody fusion?
Yes, that is when you take a little bit of a different angle and you go anterior to the nerve root, not posterior to the nerve root. You don't go through Cambin triangle, you go anterior lateral, direct lateral. This is a hot topic in the spine. So let's come back to that you know, that these patients are tremendously demanding to anybody who has to deal with them, but as well, their life is really miserable. And exam is difficult. They're just getting them to your office is difficult. Providing care to them is extremely difficult, and the risks are much higher. Those risks include, you know, surgical risk per se, bleeding, infection, risk of infection is significantly higher, and obviously as well recoveries. As well, this is a mechanical problem. Spine problems are mostly mechanical problems, and they as well are going to be much less in favor of these patients that have to recover from this kind of procedures. So we have to choose our patient very carefully, and that is why for the open surgery, most of societies now recommend for open surgery not to give them even the option of the surgery with the BMI above, at least for elective surgery, not for BMI above 40. Okay. Now, if you have to deal or take care of this patient, it's obviously, you know, that is not maybe not the medical part of it, but in a way it is. We often tend to assign guilt, like you know, how can you let yourself go and so on, and this is not unusual at all. You know, when I put this thing sometimes online, some of our surgeons, sometimes younger, who are proud of how much they work out in a gym, the first knee-jerk reaction to that is, you know, they have to take responsibility and so on and so forth. Let's talk a little about the obesity and epidemic.
Pandemic. Yeah.
It's a pandemic in US. What do you think? What percentage of, if you would just guess, of the obesity is genetically related? What do you think? What it is? Why are we obese?
I mean, I think genetics is a big component, but I also think that there's a big cultural component too.
Yeah, there's definitely both sides of that. But where are obesity is obviously rampant in the United States, and in Europe is not as big as. And but let's go back. Who are the people who are most prone to be obese?
Actually, well, it was this flip. So it used to be rich people, but now it's lower income people who are more likely.
Yeah, no, but I mean, like, so what are the biggest, highest problem with the BMI? Samoan, Hawaiian.
Are you talking about populations and ethnic groups that have seen
Yes.
extreme
Who are the
famines?
most prone to obesity?
I think, I don't know if I'm right, but Southeast Asians, when they've experienced extreme famines, now data shows that they are the most prone to obesity, because in a sense of epigenetics.
I
As in
like
the
what
ones
you
that
said.
survive.
The epigenetics plays a role,
Yeah.
but if you notice that European are generally less obese than like African or Southeast Asian or Samoan or Hawaiian, lots of people who have been, like living still to way our ancestors used to live, they are more prone to be obese. Like, let's talk about that. Like, what is obesity? That our body takes the food, you eat a whole deer, and your body turns it into fat.
We have an overabundance of supply of food, and it's also the lack of living an active lifestyle. Because like genetically and evolutionarily wise, we are made and designed to store fat because that is how we will survive, because you don't know when your next meal will come for a while.
Yeah, if you go like, for example, to some folks in Africa who still live that way, meaning that they are still hunter and gatherer, are they fat? No, they are not fat. Because yes, they go and kill an animal and no refrigeration. You have to be able to eat it all and restore it, store it as a fat, because you may not eat for the next 3 months a good meal, okay?
But I'm sure if you brought that group, put them in our country or our world, they would probably gain fat and become obese in an exponential speed.
There is no question about that. These are people that are the most prone to have high BMI on obesity, because their system is made to be efficient and survive famine. Now, if you take the European, you put them in Africa, they all starve because they cannot eat as fast and as good as efficient. So this is actually what made us survive. But now we have abundant of calories, and our body still have this drive, take as much as you can, because you may not get anything in the next 3 months. And now you put it on, but then next day you have another abundant thing. And we add to that in a different way, which is even worse. There is a book called The Dorito Effect. It's highly recommended. Everybody should read that. Now, our system is fine-tuned to get certain things that we get rarely. Those are salt, fat, sugar, and combination of that, and things that present to us that these things are abundant. So some chemical substance that tells us this is a rare thing, your body needs it, eat as much as you can from it. And now the Dorito Effect, the book is actually present how we are able to produce this chemical substance that trick our brain in and put it in everything, in Doritos. Have you ever been able to eat only one Doritos?
No.
So that is why it is, because and this is a science, and this is an active science. They didn't just come up with it. They do research on that, how you eat 5 times more Doritos than you should, because they want to sell 5 times more that you would naturally eat. Now, this is a study. They took these children, they put them in a place they can play, and then they put natural foods, things that are not altered, like fruits and grains and so on and so forth. And they did follow them up with the metabolism. The kids, they truly took, as long as it was natural, they took what they needed. Like if somebody was low on potassium, they ate more bananas. If somebody was this and that, when they followed up, and it makes sense, right? Our biology is fine-tuned over millions of years to take what it needs. There is a disease that the pregnant woman, they eat most horrible, funky, and disgusting things. Do you know what I'm talking about? And
They get the
cravings and so on. Some women eat literally soil and so on.
Oh.
But if you look into that, that is how marvelous our biology is. That like in the soil, in the soil part of the plants, they have like selenium and so on. If they need that for the baby, all the inhibition goes away and they eat the most disgusting things because that's what the body is. That is how fine-tuned our body is now. But now you trick our body by putting things that doesn't tell the rest of the things is there, like certain molecules. They tell us there are certain amino acids that are good for us, and we need that, it's there. No, you just put that molecules in abundance without all the things that the nature usually package them together. So when they did those same children, they put in with the artificial flavored stuff and so on, like vanilla, right? What percentage of vanilla that we eat today is really from vanilla?
Not a lot.
Not a lot, less than probably 2%. The rest of it is chemically produced, and literally there are these about 5,000 to 6,000 chemicals that we have refined. We can make any food, anything. We can make plastic taste like chicken. And this is a science. I mean, literally, they can combine things and add those flavors to that. And some of those flavors, they trick our brain. Now, obviously, that is why I think what you were coming that now, the obesity is a problem. It used to be a problem of the rich people. Now it's a problem of the poor people, because the rich people are going more through organic and natural things, and the poor people have to buy things that are available. And guess what? It is just a pandemic in the United States. In Europe, they have more kind of rules and regulation regarding what you can add, what you can, things that we call here organic, they wouldn't even qualify as organic in Europe. So they are, they put some active effort in the prevent this kind of concept. We understand it, they understand that, they're just better at that than us. So that like cheese, many things that are called cheese here in the United States, they're not allowed to be called cheese in Europe.
Right.
Like
I know something came out about Subway, and I think it was their bread, and I think it was in Ireland or Europe, I forgot where, but they said this can't be classified as bread, so you don't get the tax break to call it bread, which is a necessity for people to survive because there's too much sugar in it. And things like that. And I think we can learn from that here, because make no question, people like we just showed you, they are a huge burden to themselves, to their families, to medical and the whole society. And the part that I hate about the spine community, that there is this attitude, it is their fault, therefore it's okay to let them suffer. This is unbelievable. It is out there. I put it out there. Even best surgeon, best doctors, they have a hint of, that they let themselves go, so they deserve this. Whereas I can tell you, I can push a place in your brain, make you starve, and there is another place in your brain I can push and make you in 1 month gain 200 pounds. And this is, I'm talking about your the hypothalamus. Okay, they are the ventromedial, the thing of your hypothalamus. If I manipulate certain less than 1/3 of a gram of tissue,
they put electrode in the brain of the monkeys in that area. Those monkeys, they would prefer to push the button and give themselves stimulation there rather than eat. They're all starved. Okay, so don't ever think that you are above it and so on. All what you are is electric activity in your brain. And this is a combination, a harmony of things. If you bring this out of balance, it is that the whole thing of controlling yourself and so on become relative once you understand how your brain is working and how all of us are susceptible to that. And this chemical substance that we put in our all our foods and so on, they're extremely potent to trick people to get away from all the safeguards and so on and so forth. So if you get into medicine, never ever blame an obese person. It is like you're blaming an old person to be old, right? If you do that, you really shouldn't be in this business. We are here not to judge people, but to help them the way we can. And I'm seeing these obese people as that they are just deserving that. I think that's unbecoming of our profession. Okay, that is a little more than just our case review, but I think that's necessary. Okay, so
and that's what we're here to do: educate and bring awareness to these issues.
Exactly. Well, this is 5 o'clock. I think we covered few things. We didn't cover even 2% of what is really goes with the obesity, but we covered a little of interpretation of the pictures. We covered what really matters, the difference between open surgery and MIS surgery, why they recover so much better. And then obviously we talked about a little of philosophy of the obesity, how to deal with them. So some last final remarks. What question do you guys have for us? I think we should continue this and talk a little about the problem of the obesity on the medical side, what other diseases are associated with that. And especially it comes to my mind, diabetes and hypertension and cardiovascular disease. Mm-hmm. But that would be something, Neil, you and your group, you can come and give us a presentation about that, what are the medical side, because I think your knowledge might be even fresher than mine on that. Okay. So
yeah, definitely. I can try to get a few of my classmates and we can try to create a lecture for that.
Now, the preview as well, maybe Amanda talked to you that in summer, we want to create a course, a suture course.
Yeah.
Like you and some of your group, we have to find out what is a good number is. People can apply. If you hear that, apply to Neil and Amanda, and then we will bring you here. We house you. You have to come yourself, but we house you and we get you some Doritos and other snacks. But then we get.
Does it come with a Dorito book or just Dorito?
Well, maybe we should get a Dorito book for you guys. But then we teach you how to do suture techniques. And as well, we teach you about wound management. We are good at that. We will teach you that. If you're interested, apply to Neil and to Amanda. But I hope you enjoyed this episode. But if you have any questions, comment, we will try to answer it the best we can, okay?
Sounds good. Yeah, thank you so much. I know a lot of students would be interested in that. I'll be able to get a number soon once we figure out our schedules.
And on top of that, we will put you in a bus and we get you to a lake house over the weekend in Alexandria, so you can have as well some fun and lake activity. Apply, tell us why you want to be part of us. We teach you how to suture, how to do wound management, and then you can have a weekend fun in Alexandria on one of the beautiful lakes. Okay?
That sounds great.
Okay.